The goal of Imaging DMD is to develop MR imaging biomarkers that allow us to accelerate therapeutic development. We are working hard to develop biomarkers that are very sensitive so that we can have trials that are shorter in duration and can be done in a smaller patient population. Another part that's really important is that we really want to have a definitive readout of a drug. And the MR images provide a picture that is not influenced by motivation. The data are the data, and that is really important when you're doing clinical trials. The imaging biomarkers that have been developed as part of the Imaging DMD project have already been used in a number of clinical trials to help make a go, no-go decision and really provide an unbiased readout of the efficacy of a number of different drugs. As part of our growth, Imaging DMD moved from being a NIH study at 3 sites to now having a clinical trial network that involves 30 sites across the United States and Europe. With additional funding, we will develop imaging biomarkers that can be used in non-ambulatory patients so that boys that are no longer walking can be used in clinical trial. Unfortunately, this is the population that is often left out of clinical trials. Another important focus will be developing biomarkers for patients with Becker's muscular dystrophy, which is another underserved patient population. In these patients, we really want to also understand what the link is between dystrophin levels and ultimately the muscle quality, because at this point we don't know how much dystrophin is needed to maintain muscle quality. Working with the boys with Duchenne and their family has really been a humbling experience. Our team is always so inspired when the boys come here and we get to interact with the families. Remember, we have worked with many of the boys for many years, and so we really get to know the families. It often feels like a family experience, like we're all in this together to try to make a difference for the children with Duchenne. I'm optimistic that within 5 or 10 years that there will be an effective treatment for boys with Duchenne muscular dystrophy. There are a number of therapeutic targets right now that have the ability to slow down disease progression and improve the quality of life. And our hope is, of course, that our MR biomarkers that are so sensitive that they will help us get to this point even faster. Hi, I'm Krista Vandenborne, and thank you so much for inviting me here today to share with you some of the data from Imaging DMD. The goal of our work is to develop imaging biomarkers. We know that in rare diseases such as Duchenne muscular dystrophy, it's really challenging to move drugs all the way from an animal model ultimately through the different stages of clinical trials. And there are a number of challenges that one can experience. The one that we've really focused on is the need for more endpoints. We really need ultimately a really good way to identify very quickly drugs that may be effective and unfortunately triage out really quickly the drugs that ultimately may not work. So our group has really focused on the development of MR imaging biomarkers to help in this really important task. While MR images are not sensitive to dystrophin, which is ultimately the underlying cause of dystrophin, it is very sensitive to a number of pathophysiological features that are really key features of Duchenne muscular dystrophy. So here on this image, you can see this is a transaxial image that is taken of the upper part of the leg. And typically in a control healthy subject, you will see that the muscle tissue is really, the signal is quite homogeneous because the muscle fibers are really nicely organized. On the other hand, if you look at the image here in the child with Duchenne, you can see that there's a lot of structure and you can see these really hyper-intense regions, which are really caused by the presence of lots of fat inside of the muscles. So it's very easy on an MR image to detect Duchenne muscular dystrophy. So the challenge really is that if we're developing MR biomarkers, it's not just sufficient to actually see the disease. Ultimately, we need to be able to extract quantitative information that then can be used into clinical trials. And that's really where a lot of our work is focused on. So in the context of biomarkers, we want, of course, measurements that are robust, that are high quality and trustworthy. We want to make sure that the measurements are very sensitive so that we can run trials much faster and in smaller populations. Given that this is a rare disease, this is very important. And because we're working in a pediatric population, we really want to minimize the burden on the child and make sure the measurements are as non-invasive as possible. So for all of the studies that we do not use sedation and we do not use any kind of contrast agent. So as I said, seeing disease is easy. You can see the fat inside of the muscle, but the job is to try to measure that fat and the changes over time and to do that in a really robust way. So there are two measurements that we use in imaging DMD. The first one is using proton spectroscopy. So in this case, so on the top you can see the images and on the bottom you can here see the spectra. So in a spectra, it's a non-invasive biochemical sampling technique that provides us a high confidence signal-to-noise measure. So here, if we look at the images, you can see here you have a control subject, okay? The bottom you have the spectra, here is the fat, and here is the water. And so the ratio of this fat to water, it gives us the muscle fat fraction. If you compare that to here, the child that is with Duchenne, you can see, of course, first of all, you can see that the fat peak is much larger compared to, of course, in the controls. And then here you can see the changes that we see from year to year. So these measurements are quite sensitive and a really good way to measure the fat fraction in the muscle. Another technique that we use is using what's called chemical shift encoding imaging, or DIXIN. So here, instead of taking a spectra now, we take on the left side here, you can see this is a water map, and on the right side here here is the fat map. And if we combine those two measures, we now have quantitative fat fraction maps. So for those of you in industry, this is a very valuable technique because it provides a lot of spatial information, but it's not quite as sensitive. Typically on images you have a little bit more noise. It does not give that same high signal-to-noise measure. But again, it's very valuable because it provides spatial information. So this shows you here the progressive fat infiltration that can be observed during the course of the disease. So in this case here, these are now DIXIN images. In green you can see lipid, and in red you can see the water. And I just want to bring your attention to the change that you see over the course of time. So you can clearly see here that when you start out, there's very little fat in the lower leg muscles. But obviously, as the boys get older, you can see this dramatic change, this progressive infiltration of the muscle over time. So from our perspective, the muscle fat fraction is a very good marker of disease progression that is quite sensitive. And my colleague Rebecca will show you a little bit more about that later. She has looked very closely at the sensitivity of this measurement. So here you can see, this is here the fat fraction measured in one of the upper leg muscles, particularly the vastus lateralis. First of all, in yellow, you can see that in control healthy subjects, the fat fraction is very low, okay? If we look at boys with Duchenne, even in the youngest group here, you can see that it's already elevated. And of course, you can see larger differences as the boys get older. Most importantly, we can detect the changes in fat fraction over the course of 1 year very easily, and in fact, sometimes in as short as 3 months. So the measurement of fat fraction using either DIXIN imaging of MR spectroscopy is very valuable if we want to look at disease progression. Another feature, of course, of Duchenne is the fact that the muscle is very fragile. So muscle damage and muscle inflammation that is associated with that can be detected using another technique which is called T2 weighted imaging. So we have used this technique to look at muscle inflammation in very young boys and also look at the effect of corticosteroids, which we of course know has an anti-inflammatory effect. So just to kind of demonstrate how these images look, so this is here a 5-year-old. This is a T1 weighted image of the lower leg, and you'd be really hard pressed to see disease on this type of image. On the other hand, if you take a T2 weighted image, you can see clearly the higher contrast here, particularly in this deeper calf muscle, the soleus, on a T2 weighted image. And this becomes even more prevalent if you suppress all of the signal on this image that is coming from fat. So T2 is a really good way if you want to look at muscle inflammation. So as I pointed out earlier, it's not good enough to just see it. You really have to be able to quantify it. And so for that purpose, we take images at multiple echo times, and then we essentially look here at the decay of the signal over time. And if we do that for every single pixel in the image, we have what we call a T2 map here. And so in this case, all of the pixels on that image now have quantitative information. These type of measurements are pretty easy. They have excellent reproducibility, and they can be implemented across many sites. So here are some of the results looking at controls versus boys with Duchenne, and looking at particularly the effect of corticosteroids. So these measurements were done in very young boys, so 4 to 5.9-year-olds. And you can clearly see that the T2 values in subjects with Duchenne is elevated. And most importantly, you can see that the boys that are not on corticosteroids have very high T2 values, which are then lowered with corticosteroids. Again, just to demonstrate the sensitivity of T2 to corticosteroids. Here shows also the effect of initiation of corticosteroids. So we wanted to know how quickly we could see the effect. And so on these images here, you can see on the left side, you have images on the top of control healthy, and you have the T2 value here is 31 milliseconds. In the middle, a child that is corticosteroid naive, very high T2 values. And then at the bottom, a child that is taking corticosteroids, showing a lowering of these T2 values. So when we looked at the change over the course of 3 months, you can see that the MR measurements is really sensitive, with almost a complete dichotomy after just 3 months. So T2 measurements are able to detect the effect of corticosteroids over a period as short as 3 months. We also looked at the effect of corticosteroids at disease progression in terms of muscle fat fraction over the course of 1 year. And so here what we demonstrate is that boys that are on corticosteroids have a much slower progression. So the changes in fat fraction in both muscles that we measured, which is the soleus in the lower leg and the vastus lateralis in the upper leg, that they both show that corticosteroids results in a smaller change in fat fraction, so supporting the effect of corticosteroids. So at this point, I'm going to hand it over to my colleague, Rebecca Wilcox, who has really been focused on determining how well the MR biomarkers ultimately relate to functional endpoints and how well they predict the functional endpoints.
I'm Rebecca Wilcox. I've been a member of the Imaging DMD team for a long time, and I'm going to talk a bit about how the MR biomarkers we measure relate to function. It's really important to us to investigate that relationship because functional outcomes reflect something that's meaningful to individuals with DMD. The graph shows the relationship between the speed an individual can walk or run on the vertical axis and their fat fraction in the vastus lateralis on their horizontal axis. And you can see that as fat fraction increases, walking or running speed decreases. We can quantify that relationship using the correlation coefficient, which are here. We find strong correlations between the 6-minute walk test and MR, between timed function tests, including running, stair climbing, and getting up from the floor, and with the North Star ambulatory assessment. We also see strong correlations between arm MR biomarkers and upper extremity functional outcomes. In addition to relationships with function, we wanted to understand how these biomarkers were related to loss of function. So on the left, we have the survival curves. So the percent of the population that's able to perform a given skill against their vastus lateralis fat fraction. And you can see that as fat fraction rises, the percent of individuals who can get up from the floor in red, climb stairs in blue, and walk declines. But at low fat fractions, all of the boys can do all of the skills. That is also shown in the bar graph, where when we group individuals by their vastus lateralis fat fraction, we can look at what abilities they retain, what abilities they still have. And these are all ambulatory individuals. And we can see that at low fat fractions below about 0.3, virtually all of the boys can still get up from the floor, can still climb stairs. Whereas at higher fat fractions, they're more and more likely to have lost at least one of those abilities. That's especially important when we look at the future. So here we see bars for the same group of boys 1 year and 2 years later. And we can see that a low fat fraction at baseline, if you're in that less than 0.1 group, almost all the boys are still walking, climbing stairs, and getting up from the floor 2 years later, whereas boys with higher fat fractions are at much greater risk of losing ambulation within 1 or 2 years. And we've been able to confirm that using statistical analyses and shown that there's a strong predictive relationship between loss of function and MR biomarkers. One question we're asked a lot is why we need these MR biomarkers if they're so closely related to function, since MRI requires an expensive machine and functional tests are easy to perform. And I think these data tell that story nicely. So here we've taken imaging DMD participants and followed them over their first year in the study and looked at how much their 6-minute walk distance changed. And they're divided here into quartiles, into 4 groups. So we have 2 groups of boys whose 6-minute walk distance got worsened over a year, who walked less distance at 1 year than they did at baseline. We have 1 group of boys whose 6-minute walk distance stayed about the same, and 1 group of boys who actually walked further at their second visit than their first visit, which we know happens in Duchenne as growth and maturation occur, especially in younger boys. But what we saw when we looked at the MR biomarkers is that each of these groups of boys, even the boys whose functional outcomes improved, experienced declines in muscle quality. We saw increases in fat fraction and increases in MRI-T2 across multiple muscles. What that means is that we can use these MR biomarkers to detect the impact of Duchenne on the muscle earlier in the disease process. We think it's very sensitive in young boys with DMD, and thus we can evaluate the effects of therapies in those young boys. The sensitivity of the MR biomarkers to disease progression has been an important focus of our research, and one of the key markers we use of that sensitivity or that responsiveness to disease progression is the standardized response mean, which we calculate as the average change over a year for a group divided by the variability within that group, the standard deviation. That marker has important implications for sample size in clinical trials. The higher your SRM, the fewer participants you need to detect an effect in your trial. This graph shows the SRM along the bottom, ranging from 0 to kind of greater than 1. And again, the higher that value, the better. And we have here the vastus lateralis, soleus, and then the average of those 2 muscles. And there's a few messages here. First is that in early ambulatory individuals, that is individuals, we defined it as individuals who can still get up from the floor, we see that the vastus lateralis fat fraction is more responsive to disease progression than soleus fat fraction. That shifts as boys move through their lifespans, such that in non-ambulatory individuals, the soleus is much more responsive. What's notable here, though, is that the average of those 2 muscles, the average fat fraction, is the most responsive variable at all disease stages, so all the way from 4-year-olds to 20-year-olds in our sample. That has important implications for clinical trials because it raises the possibility that these biomarkers might facilitate clinical trials with broader inclusion criteria, since they don't rely on ambulatory status to be used. Dr. Vandenborn is going to talk now a bit about how we are and have and will move these biomarkers into clinical trials. Thank you.
So thank you, Rebecca, for sharing those data. So at this point, we have really collected a very comprehensive data set as part of our multi-center natural history study with over 1,000 subject visits, with 175 boys with Duchenne muscular dystrophy, providing longitudinal data over 1 to 9 years. So we have worked for a very long time with many of the families. In conjunction with the MR measurements, we also always take functional endpoints. We take the medical history, genetic mutations, medications, urine samples, blood samples, and DNA samples, and we place all of these data into a biorepository. The biorepository is shared with the larger community. Our goal is really to take all of this valuable information that we have and help advance therapeutic development in Duchenne. So the data that have been collected already have really had a huge impact on the field. One, the data have been shared with both academia as well as drug developers to develop and improve clinical trial design. All of the MR measurements have now been used in 6 clinical trials. In addition, the natural history data have served as external controls for clinical trials or to augment the placebo group. So in particularly in open label clinical trials, these natural history data have been extremely valuable. And at this point, we're really trying to take this data set to the next level by using disease trajectory modeling and to support the submission to the FDA and EMA for regulatory approval. So the Imaging DMD group has also grown. Originally, we started out with just 3 sites. At this point, we have a large Imaging DMD clinical trial network with 30 sites across the United States and Europe that are participating in phase 2 and phase 3 clinical trials. Okay. So I'm really excited to share with you this new project that we are doing in collaboration with CPAD, as well as the Duchenne Imaging Biomarker Consortium. And the goal of this new project is to model the data, so to understand the natural history disease and ultimately develop a clinical trial simulation tool. So let me just briefly explain this. So what we're doing is we're taking all of these existing data here that have been acquired as part of the Imaging DMD over the last 10 years and that we're still collecting. We're taking these data and we are placing them in a large database. We are modeling the data so that we really understand the changes that happen in muscle without the drug, and then seeing how we can really ultimately predict the effect of the drug. And so for that purpose, we are building a clinical trial simulation tool that will be made available to the public. So this is really exciting in my view and is going to be really immensely valuable to the larger community. So just to give you an example here, so as I pointed out, we understand the changes in fat fraction in muscle really well. So this shows you here fat fraction in the vastus lateralis taken in lots of boys over time. And so we know that it follows kind of the sigmoidal function whereby we have a slow progression until the boys are about 9 years old, and then this rapid increase and leveling off. So at this point, we have modeled the trajectory in a number of different muscles. They all have different slopes and different rates. And depending on which drug you're looking at and the inclusion criteria, you might select one muscle versus the other muscle. So as a proof of principle, we looked at the effect of corticosteroids based on the natural history data that we have collected using this disease trajectory modeling approach. And so what we see here is you have fat fraction, this time in the soleus muscle, which is this lower leg muscle here. It's one of the calf muscles. You can see the trajectory over time. So you see the sigmoidal function in both groups, the boys that are corticosteroid naive, as well as the boys that are treated with corticosteroids. But you can see this shift in time clearly. And in fact, the age at which 50% of the muscle is replaced is shifted by almost 5 years. So this is just to kind of show you the value of this disease trajectory modeling, having all of these data available to look at the effects of drugs and what we may anticipate. So kind of here as a nice, as this final slide, this is kind of the overall concept for the clinical trial simulation tool. So ultimately what we want to do is have this available so that a drug developer can pick their endpoint, whether it's fat fraction in the vastus lateralis or in one of the calf muscles. They can select the patient population characteristics, the age, their time at their functional endpoints, and then we can essentially model and predict what the effect of the drug would be. So one, looking at the disease progression in the population without the drug, and then with the drug. So essentially, the drug developers can simulate the trial before actually running it. And we hope that by doing that, we can really optimize trials and really help all drug developers out there to develop better clinical trials. I really want to take this moment to thank everybody that has contributed to the success of this work. This really has been the collective effort of a small village. First and foremost, I want to thank all of the families that have traveled to our sites and have contributed to the data collection. I want to thank our advisory board. We have been so fortunate to have many experts across the country help set the vision for imaging DMD. Our funding agencies, and particularly Parent Project Muscular Dystrophy, and then last, our industry sponsors. Thank you all.